So, good evening, everyone. As I mentioned, I'm Andrew Velpe. I'm the Marketing and Communications Manager at Fear Free, and I will be your host and moderator for tonight's Fear Free's Top 5 in 15 webinar. We are so thrilled to have you join us. And of course, we'd like to extend a warm welcome to all of you veterinary tech students attending tonight's presentation of the top 5 pitfalls of the emergency room with the one and only Dr. Tony Johnson. Now, before we dive in, I have some housekeeping notes for you. If you haven't noticed, your microphones will remain muted throughout the presentation to reduce background noise. If you do have questions, a lot of you have already figured out how to use the chat feature on the right-hand side of your screen there. So please feel free to throw your questions in there. I'm going to be watching. We'll get to the Q&A at the end, and we'll do our best to answer as many of those as possible. Recording of this webinar will be made available to all attendees within the next couple days. So if you're just tuning in and missing it, or you want to catch this crazy action again, don't worry, there's a replay. And if you're watching the replay, hi there. This webinar is part of our Top 5 in 15 series brought to you by Fear Free, where we aim to provide you with quick, actionable insights that help you better prepare for your future in veterinary care. Fear Free's mission is to prevent and alleviate fear, anxiety, and stress in pets by inspiring and educating the people who care for them. If you're interested in learning more, you can visit fearfree.com, and don't forget to follow us on social media at fearfreepets for updates on future webinars. The Top 5 in 15 series is also brought to you in part by the Association of Veterinary Technician Educators and NAVTA. Whew, all right. I think this is the part where Dr. Johnson comes back on stage and I give this incredible welcome to him. So Dr. Johnson, please feel free. We are so very fortunate to have Dr. Johnson with us today. Now, here's his official bio. Dr. Johnson received his DVM from Washington State University in 1996 and became a board certified in the shadowy specialty of emergency medicine and critical care in 2003 after doing his residency in Portland, Oregon. He is currently an ER specialist for Noah's Animal Hospitals in Indianapolis and a minister of happiness for VIN, which means he basically tries to keep all 300 consultants happy, connected, and productive. And if I'm not mistaken, he's also in charge of mimosas and bellinis.
That is correct.
He used to live in a converted one-room schoolhouse in the middle of a cornfield, but his family has since taken up occupancy in a normal house in a normal neighborhood with very little corn. Him and his wife share 2 sons and a daughter. His wife, Gretchen, is also a criticalist. Her favorite shape is a trapezoid. Interesting. And in his spare time, when he's not working, he enjoys sleeping, eating, breathing. That's a good one. And with the occasional foray into woodworking, wine, movies, raising a family, cooking, drinking whiskey, raising chickens, reading and writing, but certainly not arithmetic. I have exhausted my breath. It is now time to welcome the one, the only Dr. Johnson. Everyone give a big 5 and a virtual round of applause for Dr. Johnson. Dr. Johnson, the stage is yours, sir.
Thank you so much. Let me try and get my presentation going. Thank you for that very exciting, dynamic. Here, you're going to travel through time for just a moment. Hold on.
The Matrix, folks.
Yes, for sure. But thank you for that intro.
You're very welcome, and I will turn it over to you, sir.
Not that. Hold on.
Oh, he's making new slides.
Tell me. Nope. Same old slides. Okay, so tell me when you can see. There we go.
There we are.
See okay.
All right, the stage is yours.
Welcome.
I will see you at the end.
Okay, sounds good. Thank you so much. I really want to encourage you guys to put questions into the chat. I'm told that you guys are a more interactive bunch than the veterinary students last night, who were a little quiet, a little reserved. So I want you to sort of do some rabble rousing into house. But thank you for being here and giving up part of your evening while we discuss the top 5 pitfalls of emergency medicine for technicians. And last night I went way over, so tonight I've kind of trimmed this down and trimmed the fat a little bit. And I wanted to share just a couple of thoughts. We jump in. I could not do what I do without you guys. The ER is a busy, hectic place, and my ER technicians keep me focused on task. They sort of spin me around and be like, Johnson, you got to go into room number 5 next. And they're good at reading my mind and knowing, like, hey, Johnson likes to do X, Y, and Z, and doing that. And so this is a case of that last night, where we had this little guy who was just the angriest little chihuahua ever. Like, he looks cute. He wanted to eat you and kill your whole family. And I had an animal control officer who came in with an unfortunate DOA dog, but she was just the nicest. And she was like, "Hey, you guys look like you need a hand." And she helped out with this little dog, who did just fine, ended up having some pelvic fractures, which we can manage medically. And that's my technician, Jenna, there, who keeps me on task and points me into the next case. And just to sort of highlight the unpredictable nature of the ER, this is obviously around Halloween. It was just a normal night of, vomiting and diarrhea and abscesses and whatnot. And in strolls this, which, as you couldn't tell, is a goat. I don't have ever treated a goat before in my life. This was an absolutely adorable goat who, I think his name was Winston. He got kicked by a horse, had a fractured tibia. We gave him a little bit of butorphanol, which apparently, is kind of worthless in dogs and cats, but works great in goats, and splinted his leg, and he's doing great. So my first goat patient in 30 years. Andrew gave little glimpses into his family and furry friends and all that. This is one of our chickens. We have 3 right now in suburban Chicago. They're goofy, funny little things. They eat all the food that my refuse to eat, and my daughter is obsessed with sneaking them into the house. And this is one of our chickens roosting on top of our parakeet cage and probably pooping on its head. So if any of you live in a place where chickens are legal, I would encourage you to get them. They're super fun. It's awesome to get the eggs. They're easy keepers, just goofy little dinosaurs. More of my family. My heart dog on the right, Gwen. I adopted her when she was like 3 months old and the size of a canned ham. I came into work and she was wearing a little pink tutu, and I just couldn't pass her up. And on the left is my heart cat, Joseph. Not a heart cat because he has a heart condition, but just because he is my soulmate. He is a bottle baby, but unlike most bottle babies, is not a nightmare. He's an awesome cat. He's like a lab trapped in the body of a cat, and he and Gwen get along. They were just cuddling on the couch today. Whew. Okay. I need to refill my Red Bull, I think. So, okay, we're going to start a little slow. Number 5, urinalysis. And the reason I throw this in here is because when we're doing a workup, you got a sick patient in, maybe it's been drinking more, maybe it's been losing weight, maybe you just are doing a senior panel. And it's easy to get blood. Like most people can hit a jar and get blood. Urinalysis can be a little bit more challenging. Maybe the patient has a tiny bladder. Maybe you don't do cystos in your practice or whatever. But I would encourage you to get a urinalysis part of a complete workup for a bunch of reasons, particularly those of you who are in the ER. And one of the most important things is when a patient comes in and their kidney values are elevated, that could just be from severe dehydration. So if you have a patient that is sent, let's say you work in the ER and it's sent to you for care, and their BUN and creatinine are elevated, until you know what their urinalysis look like, it's really hard to tell if that's just severe dehydration versus is there something really wrong with their kidneys, like chronic kidney disease, leptospirosis, lymphoma, all those things. We get a lot of patients referred to us in the ER as a sick diabetic, but if you don't do a urinalysis, in some cases you won't find ketones in the urine, which really kind of changes the flavor of the case and sort of changes the financial implications for the owner, the length of hospitalization. And a free catch UA in the vast majority of cases is just fine. You really only need a cysto when you're going to culture it. So you're looking for a UTI, if you're looking for urine-specific gravity, if you're looking for ketones, a free catch UA in the vast majority of cases is just fine, and that makes life much easier. All sorts of things you can see on there when you're trying to work up. Do they have a UTI? Are they losing protein into their urine? Tons of other things. So it really, in some cases, can tell you more about a patient than a CBC and a chemistry. And I'm not going to go into a ton of physiology, but there is some of it that I think translates to the clinic that is important in terms of looking at both blood work, overall patient status, and a urinalysis. So when your kidneys are failing, so you're born, let's say you're born with 100% kidney function and you're a cat, and at 12% your kidneys start to, they've been working for 12 years, they start to go downhill. Once you get to the point where half of your kidneys are not working, that's where you really can't make concentrated urine anymore, and you get into that what's called the isostatin uric range. So as you guys are doing the UA, you're looking through the refractometer. Patients who have dilute urine, it may be that they drank a bunch of water. It may just be that they have diabetes and their urine is dilute, but it also could be that they have pretty significant decrease in how much kidney is working. So when you see urine that's in the range of 10.8 to 10.12, that is a patient who you kind of may have to look a little closer at everything. Once you get to the point where 3/4 of your kidneys are not working, that's where you see elevations in blood work. So really, just from this, you can see that urine specific gravity is a more sensitive indicator of how well your kidneys are functioning than blood work. And we, all the time we'll do a pre-dental, we'll say the kidney values are normal. He's got the kidneys of a 3-year-old. But if you read and take this to heart, you could have a patient with a normal BUN and creatinine that has 74% of their kidney not working and still have normal blood work. So the flip side of this, and I just had this happen this morning in a patient who I was seeing in the ER, he happened to pee on the floor. We got it. The urine specific gravity was a cat, was greater than 1050, super concentrated urine. And I could tell the owner, like, you know what, this is a good sign. It means your cat's probably dehydrated, but it also means we know he's at least got 50% of his kidneys that are working. And it was a cat that had some issues. He'd been losing weight. So I could say this is definitely not a kidney disease. Where I use this often in my hospitalized patient is if I have a patient who's been on fluids in the ICU, let's say it's something like a parvo dog, and they're puking, they're having diarrhea. We're not sure if we're meeting their fluid needs. And we get a morning urine sample and their urine specific gravity is concentrated. And concentrated to me means, I don't know, greater than 1030 in a dog, greater than 1035 in a cat. I probably am not meeting their fluid needs with my IV fluids. But where I really think the most important thing is for you guys is if you pull blood work and the kids are normal, yes, that's good news. That means we have at least 25% of the kidney that is working, but normal blood work does not mean normal kidneys. And we mislead owners with this all the time. And where you may have seen this happen in real life is the 14-year-old Yorkie, you do pre-anesthetic blood work, the renal values are normal, it's under anesthesia for 2 hours, maybe somebody gives it a dose of a non-steroidal anti-inflammatory, and then 2 or 3 weeks later they come back, they're vomiting, their kidney values are abnormal, and they're in acute kidney injury, acute renal failure. So this is probably a patient who had just 26% of their kidney that was functioning. The anesthesia, the low blood pressure, the anti-inflammatory drug tipped them over into kidney failure. So just remember that normal blood work does not mean normal kidneys. Number 4, we'll talk about primary survey and triage. So I'm an ER guy. My main focus is ER patients who come in and how we manage them. And a huge part of that is my technical staff. And as I said at the beginning, I could not do what I do without my technicians. Like, I'm just sort of the guy in the white coat who goes in and kind of looks what they're doing. The techs are the ones who actually deliver the care, comfort the scared owners, treat the hurting pets. Like, they're the ones that really deliver on the promise of what veterinary medicine is supposed to be, and that's you guys. So primary survey and triage is really important. The primary survey is when a patient comes in on a gurney, they've just been hit by a car, have some sort of trauma. It's easy to get distracted by, this dog who had a laceration to his tongue that bled all over. That's a big dramatic thing. The owners are freaking out because there's blood. The dog's covered in blood. The ER is covered in blood. But what if the dog that got hit by a car that actually had a collapsed lung or was bleeding into his abdomen? So the ABCs, which is airway, breathing, and circulation, that's how you can really ground yourself when you get these patients that come in that just basically kind of look like a disaster or death eating a cracker. So A is for airway. In most cases, I think I've seen 4 choking patients in 30 years. It's very uncommon. So airway usually is fine. Dogs with laryngeal paralysis, maybe that's an exception. Brachycephalic breeds and dogs with tracheal collapse, that's an airway issue. B is for breathing. That's very important in the ER and in trauma patients. So heart failure patients, patients with trauma with its lung, cats in severe asthma. So B is for breathing. We assess that, evaluate it, and do that before we do anything else. And then C is for circulation. So we're looking at things like what's their mucous membrane color, what's their pulse quality. If you want to put numbers on it, their blood pressure, what is their lactate, what is their heart rate. So the ABCs seems like sort of kindergarten medicine, but I've been doing this for almost 30 years. And when I get a patient that comes in on a gurney and the receptionist comes back and says, I need a triage, my heart rate goes up, my palms get sweaty, And this will ground you. This will be like, oh my God, this looks like a disaster, but this will help you prioritize what you need to do for that patient. And you address all these things before you move on to the other stuff. Anything that's a non-life threatening injury, we save that for later. And this is where the priorities of the medical care delivery team, you and the doctor, differ a lot from the owners, because owners are like, oh my God, does it have a broken bone? Does it have a broken back? Oh, holy cow, look at that giant wound. We do need to address those, but we don't need to address those before we address the life-threatening injuries first, like shock, collapsed lung, bleeding, things like that. So all those things that kind of take your eyes off the prize are called distracting injuries. And I have a very graphic, dramatic example of that coming up. And that's, the dog that has a huge wound, the dog, and I've seen this multiple times, jumps out of the back of the pickup truck while is dragged for 10 miles. They may come in and one of their legs has been ground off by the road, but unless they're spurting blood, that's not the thing that's going to kill them in the short term. Maybe they've got a collapsed lung, maybe they got bleeding into their brain. So you have to really prioritize the things that are a direct threat to life immediately and take steps to deal with that before you move on to the orthopedic injuries, the neurological injuries, the ocular injuries, that kind of thing. Keeping owners informed, I'll talk about communication later, but it's always this interplay between, you don't want them to wait for 2 hours when their hit by car dog has come into ER. You may go, like what I'll often do is go in and introduce myself and say, hi, I'm Dr. Johnson. I understand your dog has just been hit by a car. Our priorities right now are the things that are a threat to life. So collapsed lung, internal bleeding, that kind of thing. I'm going to go evaluate him. I'm going to treat for pain, and then I will come back and talk to you later. And so I like to keep the owners informed as we sort of are in this early stage. And they often are scared spitless. Like they, are terrified. They are afraid that their dog is hurting. They're afraid that, we're not taking appropriate care of their dog. So trying to sort of set their expectations and let them know that, yes, we care. We're on pain control, life-threatening injuries first is very important. But I'll talk about how sometimes that can create monsters.
And Dr. Johnson, just before you go on, this is so informative. One of our viewers pointed out, if you wouldn't mind hitting the little hide button at the bottom of your screen there.
Yes. Yep.
That would be great. They're finding it distracting. Okay. And speaking of distractions, I'll hop off the stage now.
Okay, that's fine.
And
welcome
also,
distraction.
Perhaps move the cursor as well.
Okay, moving the cursor. There we go. Okay,
Sorry
is
to
that better?
Carry on. The floor is yours.
Okay. So speaking of distracting injuries, so this is I saw not too long ago with an obvious dramatic injury. You can see there's an open knee right there, huge soft tissue injury, but there is no blood. So this is obviously going to have implications for the rest of the dog's life. It is not going to necessarily have implications for the next 10 or 15 minutes. What if this dog was also bleeding to death internally? What if this dog also had a collapsed lung and couldn't breathe? So this is a perfect example of a distracting injury. So yes, we note it. Yes, the owner is obviously concerned about it. Yes, it's going to change the whole course of this dog's life. But this is probably not going to kill the dog in the next 10 or 15 minutes, like a collapsed lung or a bleeding splenic laceration. So I'm sorry that this is so super graphic, but I just wanted to kind of point out this is a real life recent case that I had in the ER. And I think this dog also did have some internal bleeding, which we found out when we ultrasounded the dog as part of his triage exam. So primary survey and triage, I talked about the ABCs. What are some of the things that can't wait? And I work at really good ERs, excellent trained staff, excellent front desk people who kind of, know how to deal with stuff. But there are certain things that can't wait. Still, we'll go into a room after things been waiting, 20 minutes, an hour, 2 hours, and be like, holy cow, how did this thing end up in a room and not in the back? So trauma patients in general should be rushed to the back for evaluation. Anybody, LOC is level of consciousness. So anybody with an altered level of consciousness, like seizure patients, coma, little kittens, little Yorkies that are flat out because they're hypoglycemic, patients with active hemorrhage, either internal or external. Little obstruction cases, cats in general, in my case, we triage them. We say, okay, bladder is very large, but you look pretty good. Those often will be triaged to kind of level 2, but the ones that have a huge bladder, flat out, they're hypothermic, those will kind of move up the thing. So urethral obstruction can come in multiple flavors. Obviously, patients who have respiratory distress or dyspnea should be triaged right to the back. They should be given oxygen and jumped on that. And then just other general sort of thing, patients with burns, patients with shock. Dystocias are not the kind of thing you want to sit around for a while because those can turn into disasters. And that's any patient who's having trouble giving birth. Okay, so that's kind of the 2-minute version triage for our veterinary patients that you guys may be involved in. Finances are obviously a big thing in veterinary medicine, and I am lucky enough to work in a place where the technical staff in the front desk almost exclusively deals with the finances. They present the present the estimates to the owners. They will go over them and kind of do that discussion and negotiation that often goes on. But a lot of times this comes when the owner makes first contact over the phone. And I just wanted to put this up there because I worked with a technician once who was so good at talking to people on the phone. And she had this little script that she used that she delivered in a very kind but firm manner. And I think this brings up a little bigger issue that maybe we should talk about in a separate webinar, in that, this is our livelihood. You guys are in general grossly underpaid for what you do and the stress you go through, but it is okay to get paid to do our stuff. A hospital has huge expenses. We have to pay our staff. We have to pay their healthcare costs. We have to pay for supplies and keep them on. So we really should get away from feeling guilty about monetizing a client's emotional distress. But where it really comes into play is that owner who calls and they may be anxious, they may be afraid. They're like, God, my dog is sick. I don't know what's going on. And they call and we discuss fees. And that's okay to do. We're trying to educate clients and let them know that, yes, there is a fee for what we do. There's no universal healthcare for pets. So her script usually, once she sort of talked to the owner and was like, okay, your male cat has been straining in a litter box, really sounds like he should be evaluated tonight because this can be potentially life-threatening and is certainly uncomfortable. The exam fee is $125. The doctor will assess your pet and provide an estimate for any recommendations. And then for hospitalized pets, a deposit will be needed and the remaining balance will be due at discharge. So this is a very quick and summary of how most ERs handle finances. And then if the owner sort of tries to go off into I can't do it, you have payment plans, all you care about is money, you're letting my pet suffer, you can sort of repeat this script because that's just the way it works. Now hospitals may have different plans. You can throw in things about scratch pay and care credit as options. In most cases, when you need it, you can't get approved for it. But it is okay to, in a firm but caring way, re-emphasize this point and be like, this is how our hospital works. There's an exam fee. We will get you an estimate. You can decline that estimate. There's a deposit that will be needed, and then the rest is due at discharge. It's not really a negotiation in this case. And you'll get people that, you have to develop a thick skin. If they start swearing or being rude, you can say, we're going to have a calm discussion. I'm afraid I'm going to hang up on you if you continue to use profanity and swear, and that's fine to do. But I just thought this was a really nice crystallized way to sort of, without sounding harsh, and a lot of it depends on your tone when you deliver it, but just to deliver how we talk about finances. So once the patient's in the hospital, let's say it's come in and the doctor has done the evaluation and meets with the technician to come up with the estimate, and this happens 20 times a shift, where I'll meet with the technician, we'll sit down and say, okay, here's the estimate for what I think is medically best. And I just had this last night with a dog that got into its owner's anti-anxiety medication. We had an animal poison control consultation where they laid out A, B, C, do these things. And I said, let's present the estimate, the best plan. We're not going to push it, but we're going to say, here's what we think is medically best for your pet. That is plan A. The owner had already said, she was a super nice lady, super nice dog, ended up doing fine. But she was like, I have 4 kids and I'm a single mom. So I said, okay, that's fine. What I'm going to do is we're going to go through an that is what poison control recommends as medically best. If that works, great, we'll do it. If that doesn't work, we're going to sort of drift down to reality and come up with a plan that hopefully meets the dog's needs, your financial needs, and my conscience. And that's way easier said than done. But what I think we forget to do sometimes is offer what's medically best and go over it. And that may be transplant, that may be dialysis, that may be going for an MRI. And yeah, you'll get those who laugh at you, who are like, I had one yesterday. Well, that MRI for a dog is $5,000. That's more than it is for a person. Just stuff roll off your back, because A, it's not true, and B, whatever. So offer plan A, don't push it, don't make them feel guilty. But then try and drift down they can do, but try and not drift down so far that you're knowingly setting a patient up for pain, distress, fear, that kind of thing, or it's going to wear on your conscience. So hard to do. Quality of life when we're discussing a really sick patient. So let's say something like a 150-pound dog that has a disc and he's paralyzed. Quality of life goes both ways. So you may be, and there are owners who will treat it. They'll be like, okay, that's fine. I'll build a sling. I can lift this dog, and my son's a wrestler and can do it. That's fine, whatever. But if you're asking this, like a little 6-year-old lady, to get her 180-pound dog outside to pee who can't walk, quality of life goes both ways. So I really have a lot more sympathy, I think, for the owner's situation now than I maybe did when I was younger and earlier out of school and had maybe a little more fight in me. So that doesn't mean everything that comes in that's sicker than a broken toenail I'm pushing for euthanasia. A little bit more sensitive to what the owner may be going through as we are asking them to treat this patient. There's a lot of bargaining that happens in this. There's a lot of cutting corners. You have to figure out where your line is. And the problem is you may be sometimes asked to do things that a doctor has said, look, I have talked to the owners. We've come up with this plan. I know it's not perfect. I don't think it's cruel to the patient. And you may disagree with that. And hopefully you're at a place where you can be heard. Your opinion counts, but sometimes it will be overruled. I listen to my technicians all the time. I take their advice. And I have one technician, Jenna, who was in the picture, who is phenomenal for offering up suggestions to be like, hey, well, don't you think maybe he needs 5 days of gabapentin instead of 4? Or, do you think he needs a sedative? He's super stressed out. And it's a discussion. It's bargaining with the owner. It's bargaining with my technicians. And I love it because she still has the fight to try and keep the patient's best at heart. It's easy to lose that fight because you will lose it a lot. But I love Jenna because she will sort of make me think, okay, I love these ideas. I'm going to do this one. I don't think this one is fly, but there's a lot of bargaining that happens. But really, you can boil a lot of this down to understanding, and that goes for the owner, your workers, the veterinarians you work with, and the patient. So try and have understanding and empathy for everybody that's in that whole equation, from the CSR down to the technician, down to the doctor, including the patient, including the owner. It's a lot. So I think this might be our last one. I was going to wrap up with fluid therapy. Andrew, are we okay on time? I will take your silence as consent.
We are on time, sir. We are good to go.
Woo! On time and under budget. So fluid therapy is a really complicated subject, and there are lots and lots of ways to approach it. And I remember early in my career, I was like, I just want the right way to do it. I want to know, like, what's the way to do it? There is no perfect way. Yeah, among experts and specialists, I work with a whole bunch of criticalists right now. We all have different ways to do fluid therapy, and that's fine. There's really not a universally accepted approach to say this is the right way to do it. With my patients, there's lots of times where I have underdone their fluids. There's lots of times where I've overdone their fluids. You just have to really look at the patient, assess them, look for changes in their status, and make changes on the fly to what your fluid therapy prescription is. And fluids are a drug. And usually when you do drugs, that came out wrong. Usually when you prescribe drugs for your patients, you will come up with a dose and a frequency. But a lot of times for fluids, we just default to, like, I don't know, put them on 2 times maintenance. But if you consider fluid as a drug, I think we should have maybe a little bit more tailored approach and change through fluid therapy plans to meet our patient's changing circumstances. But there's a lot of difference between a dog that farted twice and is going to be in the hospital on fluids, and a super sick like Addisonian whose electrolytes are all over the map, their blood pressure's all over the map. So there's a bunch of different to do it, but I would say try not to take a one and done approach to all of it. In general, we use fluids 2 reasons: either for shock and or hypotension, which is low blood pressure, or to rehydrate a patient who is either not eating or drinking or has losses, mostly through the gastrointestinal tract and vomiting and diarrhea. So when you're dealing with a patient who's in shock, you don't want to give them a huge god awful amount of fluids right at once. You want to calculate a shock dose and give them small boluses, and I'll give you a little trick for how to calculate that in just a second. And then rehydration therapy, really it should not just be set the pump at this and that's what it's going to be till they go home, except for the very simplest of patients. So when I'm rehydrating a patient, and the perfect example of this is something like a parvo dog, which if you've ever worked in just about any vet hospital, you may have encountered one. So they may come in very dehydrated. They've been puking for 2 days, got gummy mucous membranes, they've got a prolonged skin tent, they're hypothermic. So that is their dehydration deficit. So that's how much fluids they have lost over the previous, whatever, 1, 2, 3 days of not drinking and vomiting and diarrhea. They also are going to need their maintenance needs, which is how much water you need to stay alive in a day if they're not eating and drinking. And then the third part of this is, what are their ongoing losses? So let's say you see a little 5-kilogram parvo dog, very dehydrated when he comes in. He's also not eating and drinking, so we have to meet his maintenance needs for water. And then if you hospitalize him, he pukes 5 times overnight and has 5 episodes of blowout diarrhea. That's all fluid that needs to be replaced. So these are really the 3 core components of a fluid therapy plan. You put that dog on 2 times maintenance, I guarantee you he's still going to be dehydrated 24 hours later. So I don't want to make it complicated. I don't want to make more work for people. But what I do want to do is to say, look, this dog comes in and he's lost 10% of his body weight from vomiting and diarrhea. He needs 60 mils per kilo per day of water to survive. And he had several episodes of vomiting and diarrhea overnight. And we have to replace that stuff with fluids. So just try and keep that stuff in mind. Develop a plan, 2 times maintenance. Where that works out is, a dog that comes in that puked twice and he's normal on physical and you're just rehydrating him, that's fine. It's okay. Anybody who's really sicker than that, particularly something like a parvo dog or a block cat. Block cat's another classic example, because when you unblock them, their body is trying to flush all those toxins out, and the only way they can do it with the extra fluids. So a block cat on 2 times maintenance is still going to be dehydrated and is not going to get better. Okay, fluid. Oh, it's number 2. Dang, I got one more to go after this. So a couple of tips for the first shock bolus. Let's say you have a head car dog that comes in and it's 50 pounds and you need to bolus it some fluids because it's got low blood pressure. The easy cheater way to do this would be add a 0 to their body weight in pounds, and that's your first bolus. So 50-pound dog, give him 500 mils and then reassess how he's doing. Yes, there are more specific ways to do it. I'm a criticalist. I'm contractually bound to make things more complicated than they need to be. But if you want to just, talk to your doctors and be like, hey, this guy said here's a good, easy way to come up with your first bolus, that's fine. Easy fluids for stable patients. So this is not for the hit by car, the HGE that's comatose, the Addisonian that's got a sodium of, 120. But, the dog that puked twice and the owner is going to hospitalize it on fluids while we take rads and do blood work. The easy fluid for stable patients thing is take their body weight in pounds, and that is their rate in mils per hour. Is that enough to correct a massive fluid dehydration or shock? Nope. But is that fine for a dog who is stable, walking around, wagging his tail, getting admitted, and you can just set the pump until you can sit down and figure out a better fluid therapy plan? Yup. So, golden retriever that's puking, we're going to get rads, we're going to do blood work. We want to start on fluids, weighs 50 pounds, put him on 50 mils an hour. That's fine for the first 45 minutes to an hour until the doctor can come back and say, okay, I've looked at his blood work. He's dehydrated, blah, blah, blah. For everybody but patients with disorders of sodium and congestive heart failure, LRS is fine. People obsess about, is Normasol better? Is Hartmann's better? Is blah, 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 blah. anybody who doesn't have a serious disorder of sodium, anybody who's not in heart failure, LRS is fine for the vast majority of your needs. And then what I use for maintenance fluids, and the nice thing about some of the places I work at is if I have that stable patient that comes in and get them on fluids to get the ball rolling, I can say, hey, Jenna, let's just put this guy on maintenance for now. And they know maintenance is 60 mils per kilo per day for a dog, 50 mils per kilo for a cat. And they can do that without anybody having to sit down and really do a lot of calculations. So just some, fluid therapy kind of streamline things a little bit. And I will end with communication. We are all here communicating. I am communicating to you guys. If anything is going to go wrong in pretty much any general practice and kind of life, it's usually communication. And I just had this happen last night with a cat that came in. The owners were grooming the tail and they cut it. And it had a 2 millimeter laceration on its tail. So the techs, trying to be, proactive, brought the cat in back, a little squiggly. They got the okay to give Zorbium for the cat. They clipped and cleaned the tail. We really hadn't established a relationship with the owner yet. And the owner flipped out because somebody also came in and said we had shaved the cat's entire tail. She didn't know what the pain medication was that we gave. It was a busy night, and that is where communication fails you. So I had to spend a lot of time scraping this owner off the ceiling and saying, I'm sorry, it's been a busy night. Communication kind of fell through. Your cat's entire tail was not shaved. Here's the medication that was given. It's because we were very aggressive about treating pain. But it really is the root of almost all issues that happen in a clinic, and in particular, communication with veterinary clients. One thing that I really like about ER is we try to utilize what's called closed loop communication. And I had a cat named Achilles yesterday, was in congestive heart failure. And, he came in, he was in oxygen. And I said, Jenna, I want this cat to get 2 milligrams per kilogram of furosemide IM and be placed in oxygen and also be given 0.2 milligrams per kilogram of butorphanol. She could say, okay, and go off and do it. Closed loop communication is where they say, okay, you're going to give him 2 mg per kg of furosemide IM, 0.2 mg per kg of furosemide in oxygen, right? So yes, it adds to it a little bit, but that way I know that she has received what I have told her. It's not written down anywhere, but she has received the message and is going to go and do it. So that's called closed loop communication, where it's just like, hey, go to 0.2 mg per kg of butorphanol, and maybe they didn't hear you, or maybe they thought you said some other drug. I'm hearing it back from her, so I know that she said it. Situational awareness in the ER it's really easy to get in your own little silo and be like, okay, I'm dealing with this patient right now. He's super sick. He's got diarrhea. I got to give him a butt bath. But the best technicians that I have worked with can elevate themselves 1 or 2 levels above that and be like, okay, this patient's dying. This patient's in pain. What is the whole status of my ER? How many patients are waiting to be seen? What's the order? Who's been triaged? And that's tough. And in the tech world of the ER, multitasking and having that level of awareness of what's going on is something that only the best of the technicians can do. But the best technicians are the ones that keep me on task, point me into what needs to be done next, and are running the show. They're like air traffic control. So situational awareness is trying to expand, not getting tunnel vision, expand your scope of what's going on, not just right in front of you, but maybe an ICU, maybe even the borders upstairs. But for sure, what's waiting to be seen, who's the worst, that kind of thing. Keeping the owner updated is super vital. I had somebody waiting 6 hours to be seen last night, and luckily the guy was totally cool with it. But if that's the kind of thing where you can have a CSR come in and be like, hey, I just want, 2 things ahead of you. If your patient status decreases, let me know. We got coffee up front. The don't create monsters thing is I have been accused of creating monsters with owners at times because I have a tendency with sick patients in the hospital to, time permitting, call them up and say, hey, just want to let you know, Fluffy just ate a little bit and his blood pressure is low, but we're going to address it, and do that like every few hours. And that to me, I'm like, okay, I let him know what was going on. That's sort of a fear-based reaction. But the problem is then if the next person in line has a different communication style, they'll be like, well, Dr. Johnson called me like 4 times yesterday. What the hell's going on today? So we do in our hospital is tell people we'll call you in the morning with a medical and financial update, and in the evening with a medical and financial update. You can call anytime and get an update from the staff. And we'll call you if there's a change status. So they kind of know what to expect. And, you know, when, a phone call is maybe good or bad, but they're not sort of expecting that concierge level care. Somebody said, call me every 2 hours. So keep the owner updated, but try not to create monsters. When you're talking to owners as a technician and you're getting a history, or they're just, I don't know, venting, try to listen more than you speak. Because owners basically want to be heard. They want to have their fears and their concerns validated. And yeah, we got to ask questions and we got to get stuff done. But there has to be this give and take between what they are saying and what we're asking. And with angry owners, this could be a whole other 6-hour seminar. We've all dealt with them. They're out there for sure. But just and when I talked about sort of empathy and sympathy, some of these owners are terrified. Some of these owners are like, this is my heart dog. I would be this way if Gwen was sick. They're terrified. And people don't deal with terror very well, just like our patients don't deal with fear very well. And sometimes that fear comes out the angry hole. And sometimes something where they are just either hurting or scared makes it seem like they're just the biggest asshole in the world. So try and scrape up, molecule of sympathy. It's hard sometimes. And yes, there are assholes in the world. Like, I'm not saying that it's always this, but sometimes it is misdirected fear and terror for what their pet is going through. And just, understand the whole purpose of what they do with Fear Free is diminishing fear, anxiety, and stress in the patients, but understand that fear, anxiety, and stress happens in our clients too. And it's part of our humanity to deal with that. And that is not an easy task. So that is it. I know we're probably over time a little bit. I'm sorry, but hopefully that was what you showed up for.
Well, Dr. Johnson, thank you so much for sharing your expertise and valuable tips with us. As you've been chatting, as predicted, our vet tech students are definitely more chatty tonight. So I've got a few questions that have come in, and I'm going to try to address them all. I'll start with Fabiola, who sent in.
Wait, can I share one? Can I just share one thing?
Of course you can.
And we're going to travel through time one more time.
Whoa.
Only because this is a Costa Rican sunset from last week. And it's a sunset in more than one way, because that is my son in the sunset right there. So we have a little house in Costa Rica that we go to escape from madness that is modern life. And I was there last week, and I know we've got some Ticos who are here, so I just wanted to share that and say thank you guys for your attention. Okay.
This is the third time this year I've heard of people going to Costa Rica, so I think I'm going to have to jump on that bandwagon.
I will hook you up, my friend. I will hook you up.
Noted. All right. Good to have friends. Speaking of friends, Fabiola started it off. So Fabiola had a few questions. I'm going to try to get through them, but I'm also want to be fair of time and also the other questions. Fabiola asked, would you consider TFAST as part of the initial assessment on an ER or as a diagnostic procedure, which would require owner's consent to be done?
Fabiola, I want you to come work for me because you know what a TFAST is and you clearly get it. So TFAST is it's an acronym for Thoracic Focused Assessment with Sonography for Trauma, which basically just means putting the ultrasound probe on the lung to look for evidence of either a collapsed lung or heart failure. And yes, I think that has moved into the range of primary survey. Now, I'm kind of a dinosaur, so I don't necessarily include it. But yes, I think TFAST and AFAST are now part of the basic assessment for anybody that comes in with unexplained hypotension or collapse. We have a trauma stabilization form or authorization that we will present to the owners, and the CSRs will ask if it's okay for stabilization and CPR. And they'll, the patient comes rushing to the back. We have these little things, they're like Star Trek communicators, about Voceras, I think, that they will then call the tech on the Star Trek communicator and say, that's Fluffy, she's 4 years old, she is a yes and yes, which means yes to stabilization and yes to CPR. So that's kind of our handy system for doing it. I will admit that I will just bust out the ultrasound for anybody because I want to know what's going on. So even if a no and no, which means no to stabilization and BR, I'll often do it, but then I just won't charge for it because I'm a terrible business person.
I mean, you're doing the right thing though, so that's what matters.
I know. That's how I sleep at
There
night.
you go. Fabiola, I know you got a couple other questions. I'm going to jump back and forth. I want to address Sarah's. Sarah asked earlier, plight fluids versus LRS. Your thoughts, sir?
So P-Light is plasma light. LRS is lactated ringer solution. Really, you could find a chart and be like, a plasma light has magnesium and LRS doesn't, and whatever. You can go crazy with that stuff. As I said, for everybody except for heart failure patients and patients with disorders of sodium. So, an Addisonian dog, a dog that was deprived of water for, 5 days and his sodium is 190. Plasma light and LRS and Hartmann's are all equivalent for treatment of shock, for treatment of dehydration. They're the same thing. The two exceptions that I can think of are disorders of sodium and congestive heart failure.
Thank you. Oh, we lost you. Your camera disappeared.
Oh, yeah, my camera's a little wonky tonight.
That's fair. At least we can hear you. While you're figuring that out, Lane asked, I think it's Laney. Sorry, Laney. And if I'm botching that, I apologize. Can you explain why the allometric scale is not used for fluid therapy very often? Is it just easier to do the 60 ml kg a day, even though it's supposed to be more accurate? I just learned about it in school, but haven't seen it in practice.
Dang, y'all are like the AP class for this. I was not expecting this. So the allometric, okay. So there's two formulas for fluid. God, you're brilliant. There's two formulas for fluid therapy. 60 mils per kilo per day is the lumping dinosaur criticalist like me. The allometric scale will tailor it to the patient's body size and is technically better. It involves exponents, which, give me explosive diarrhea. So, I can't do exponents. However, one little gem is that the calculator on your phone, on your smartphone, when you turn it sideways, you do turn it into a scientific calculator where there is exponents. Where the allometric scale is really more useful is patients that are 2 kilos or less or more than 40 kilos. And the vast majority of our patients are going to fall kind of, they're more than 5 pounds and they're less than 100 pounds. But I would say for patients at those extremes, like when I'm doing a neonate, it is better to use the allometric scale with the very terrifying exponent and the 200-pound dog you have to do fluid. So that is totally the AP fluid therapy question, and I'm super proud of you for doing that. The 60 mils per kilo per day is sort of for our bog standard patients.
Very good. Well, thank you for asking the advanced classes questions here.
Yeah, excellent work, lady.
Julie and I think it's Evely both have questions about the ABC order. They were taught that it is now BAC. So what are your opinions and thoughts on that, sir?
Oh, man. Okay. Yeah, that's a whole other 2-hour-long lecture. So BAC is, breathing, circulation. Realistically, when you have that patient that comes in the vast majority of cases, you're going to know if their airway is okay. And I think this might be a little bit more important in CPR in humans, where they've kind of gotten away from rescue breathing and are focusing more on compression. So, I don't know. I guess I'm going to kind of defer that one. I still do ABC doing it, and when I'm doing CPR, I guess I kind of understand. But I think it's because one of the core differences between our patients and human patients is the vast majority of CPR is needed for a myocardial infarction where, a big old chubby dude like me gets a little clot in their left anterior descending coronary artery and has a heart attack, whereas that kind of thing is vanishingly rare in our patients. And a respiratory arrest leading to cardiac arrest is far more common. So breathing and airway becomes more important. I think in the real world, I'm lucky enough to practice where I usually have enough people to get stuff done, where somebody is doing, getting me an airway and doing compressions at the same time. But I almost think, CAB, if you look at the data for people, compressions are the most important thing for CPR in terms of restoring circulation. And when you're compressing the chest, you're also moving air. So I guess the jury's still out on that one.
And to be continued, I'm sure. Well, thank you so much. We seem to have lost. There he is again. Perfect.
Hold on. Can you hear me?
We can hear you. That's the main thing.
Yes.
I'm just going to check one last look here. I see Fabiola has one last question to round out the night. So if we could rephrase it, would you consider the Carol Matthews fluid therapy formula has less possibilities of overflowing a patient than the formula taught at school? Fabiola.
Whew, man. Okay, this is the whole AP fluid therapy class. Like, I think you should go do a critical care residency, honestly. One thing I would say is in human medicine, where they have way more data, way more studies, they are moving towards a more restrictive fluid therapy algorithm than we are in veterinary medicine. So they're finding across, tens of thousands of patients that less fluids in general is better. It's hard to scale that down on an individual basis. But I think the more and that's why I said there's 30 parameters you can look at to tailor your fluid therapy to what the patient needs. You can go crazy trying to make the perfect fluid therapy plan. It doesn't exist. So I know that on people, the movement is towards more restrictive fluids across everything than an aggressive fluid therapy plan. However, you still have to look at the patient in front of you and make a determination based on the data you have. The data you have is perfect. So I think if the Carol Matthews one you're saying is the exponent one, I think that's probably a little bit more accurate for patients regardless of size than kind of a blanket approach like I do. But the blanket approach like I do is a starting point. And that's why I think the best thing you can do is say, we are going to start at this point, and then we're going to reevaluate the patient and see how they're doing over time and make changes to not only the fluid rate, but the fluid composition. It's really complicated. It can get really expensive. It can drive you bonkers. But I do think in general, less fluids, I don't want to say less fluids is better because some patients need a crap ton of fluids, but, sort of thinking of it as more precise fluids, I think is better. But those are all really superior, excellent questions. And I'm proud of you guys for even thinking in that vein.
It seems like we have some advanced level students here. So some great questions
sure. Please put in an application for wherever I'm working.
Well, on that note, friends, the time has come to wrap up the evening. We could probably keep this going all night for sure.
I would love to.
I mean, last night you did.
Kinda. No, it was only like we're 25 minutes over now. I think we were 25 minutes over then.
So this is the most engagement.
The audience loves it. I'm doing it for the fans.
For the fans.
Yeah.
Well, ladies and gentlemen, let's give a big number 5 in the chat. A big thank you to Dr. Johnson for his time.
And you're getting hands in return. Jazz hands.
Yeah. Of course, on behalf of Fear Free and our friends at the AVTE and NAVTA, we also want to extend our gratitude to all of you for attending this Top 5 in 15 webinar. We hope you found it helpful, and we encourage you to apply these techniques in your future practices to help reduce FAS in your patients. In the meantime, you can follow us at Fear Free Pets for more educational content and updates. We are so excited to continue bringing these webinars in the future. Our next session is on December 10th, focusing on the top 5 things you must know about proper antibiotic use in small animal dermatology. And that's going to be with Dr. Paul Broom, right? So Dr. Paul Bloom will be hosting that. You can learn more at fearfreepets.com/5 in 15. So number 5 in 15. We hope you had a great evening. Dr. Johnson, I know I did. So thank you so much for that.
This was super fun and energizing.
It really was. I told you, the vet techs, those are the ones you got to watch out for.
Oh, yeah, for sure. No, man, they run the show.
I know. We can't survive without them.
Beyonce says girls run the world, but it's really veterinary technicians. So
it's really true. Yeah. I don't disagree with that. In the meantime, oh, sorry, go ahead.
Sorry, I put my email in the chat. It's tony@vin.com. If anybody has follow-up questions or wants to explore any of these things, I'm happy to engage with any of y'all.
Excellent. And for those of you watching on the replay, it's Tony, TONY, @VIN. That's VictorIndigoNorman.com. So Tony@vin.com. Thank you for watching the replay. And thanks again to all of you joining in live. We hope you had a great evening, and thanks again for being part of our fear-free mission to make veterinary care better for both pets and people, and for supporting our mission. Dr. Johnson, thank you, sir.
Good night. Thank you, guys.
Good night, friends.
All
Take
right.
care.